Hey everyone, welcome back to the channel. I'm Dr. Irene. Before we dive into today's topic, let me quickly introduce myself for those who are new here. I'm a non-US international medical graduate, and English is not my first language, so if you're in the boat, you're not alone. I matched into my #1 ranked internal medicine residency program in my very first try during the 2024 match. Before that, I worked in South Korea at Mega Study/Mega MD, which are the largest and most competitive educational institutions in my country, kind of like a Kaplan. I taught premed students, helping them with personal statements, CV, essays, and interview preparations, and also worked as a private tutor for multiple students for the same topics one-on-one. And during my own match journey, I led a group study for Step 3 and interview preparation, and I'm super proud to say that every single one of our members matched into residency in 2024 altogether. Let's take a deep dive into one of the most essential clinical skills, the bedside presentation, specifically using the SOAP format. Whether you're a medical student just starting clinical rotations or an IMG trying to adapt to the US medical system, this skill is your bread and butter. I'll be honest, when I first started residency, bedside presentation was one of the most challenging parts for me. Not just because English is not my first language, but also because I was not familiar with how the American medical education system works. Everything from the structure to the expectations felt different. Over the past year, I've reached out to my seniors, attendings, and mentors for guidance, and I practiced, I stumbled, and I got better day by day. And now I finally feel more comfortable presenting patients on rounds. So if you're struggling, whether you're an IMG like me, a med student, or an intern just getting started, you're not alone. I hope this video helps you wherever you are. Let's break it down before we go into the actual case. S. Subjective. This is where you summarize the patient's own words, their symptoms, how they describe their condition, recent changes, concerns, essentially what the patient tells you. Think of this as the story from their perspective. O. Objective. Here we shift to the data, things we can measure, observe, or test. That includes vital signs, physical exam findings, neurological exam findings, labs like CBC, CMP, urine analysis, imaging like chest X-ray or EKG, and any other relevant diagnostic data. A. Assessment. Now it's your turn to interpret. Based on the subjective and objective data, what's going on? This is where you state the patient's main problems and your clinical impression. Be specific and prioritize the most urgent or active issues. P. Plan. For each problem listed in the assessment, what are you going to do about it? This is where your clinical reasoning shines. Include medications, procedures, and monitoring strategies. Everything that shows how you're managing the patient. Before we get started, just a quick note. This is a fictional, imaginative case created purely for educational purposes. The name, age, and all identifying details are completely made up and not associated with any real patient. That said, the clinical scenario reflects a classic, bread and butter internal medicine case, the kind of case you're likely to see during rotations, residency, or even in the ED or wards. One more quick note before we jump into the case. Throughout the presentation, I'll be using some of the most common medical abbreviations you'll see in real patient charts, like HTN for hypertension, HLD for hyperlipidemia, DM for diabetes, and so on. These abbreviations are part of everyday communication in clinical settings, so I want you to get familiar and comfortable with them. I explain anything that might be new as we go. And now, let's bring it all together in a case example. So here's our patient. This is Mr. Johnson Doe, a 67-year-old male with a past medical history of hypertension, hyperlipidemia, type 2 diabetes, not on insulin, HFrEF, ejection fraction 32%, AFib, not on anticoagulation, and CKD stage 3, presented to the ED with shortness of breath and bilateral lower extremity edema. Patient reports progressively worsening dyspnea for 3 days, orthomia, and tubular paroxysmal nocturnal dyspnea. He also noticed increased bilateral leg swelling, fatigue, and reduced urine output. But he denies chest pain, palpitations, lightheadedness, dizziness, fever, chills, cough, nausea, vomiting, diarrhea, constipation, abdominal pain, or dysuria. He also denies recent travel, sick contacts, or new medications. He has been complying with all his PTA medications as prescribed, except for furosemide, which he ran out of 5 days ago. Fun fact, sometimes patients will never say, "I stopped my Lasix." They'll say, "I just ran out of my water pill." So keep your ears open for that. Objective. On vitals, he was afebrile but notable for tachycardia with irregular rhythm. Heart rate was 102, respiration rate was 22, blood pressure was 142/86, saturation was 91% on 2 liters of nasal cannula. On my exam, he was AO times 4. Generally, he appeared mildly distressed. On auscultation, no murmurs, but lung sounds were notable for bibasilar crackles with decreased breathing sounds at basis. And also, the jugular vein was distended to the angle of the mandible, and he had 2+ pitting edema bilaterally up to his knees. The abdominal exam was unremarkable. Lab-wise, CBC shows normal WBC count 8.6, hemoglobin level was 10.4, close to his baseline. Platelet was normal 180. On CMP though, creatinine was elevated to 2.1 from his baseline 1.5 with elevated BUN 46. Otherwise, sodium, potassium, chloride, bicarb, and glucose were unremarkable. NT-proBNP was elevated to 3000s, but not very reliable, I think, given his CKD stage 3. Troponin was negative. Urine analysis was also unremarkable. Imaging-wise, chest X-ray shows bilateral interstitial infiltrates with pulmonary vascular congestion and mild pleural effusion bilaterally. EKG shows AFib with controlled ventricular rate, no ischemic changes. So you see how the numbers tell us a story here? Worsening renal function, elevated BNP, pulmonary congestion. This is classic acute decompensated heart failure. Usually during a real bedside presentation, you'll state the problem and immediately follow it with your plan, going one by one. But for teaching purposes in this video, I've separated the assessment from the plan to help you better understand the structure of the SOAP format. In real life, you don't need to list all of the problems up front. Instead, just walk through each active issue and explain your clinical reasoning and plan together as you go. Assessment. So here's my assessment, starting with one-liner. Mr. Doe is a 67-year-old male with a past medical history of hypertension, hyperlipidemia, type 2 diabetes, HFrEF, AFib, and CKD stage 3, presenting with dyspnea and volume overload. So for this patient, all active problems include acute decompensated heart failure on chronic HFrEF, persistent atrial fibrillation without RVR, AKI on CKD stage 3, chronic normocytic anemia, non-insulin dependent type 2 diabetes, and lastly, essential hypertension. P plan. Here, you share your strategy for further management, including monitoring, diagnostic evaluation, or therapeutic plans. So for these assessments, my plans are as follows. First of all, for acute decompensated heart failure, etiology is likely secondary to noncompliance of home medications. So we're switching his home Lasix PO to IV 40 mg BID for better diuresis. An echocardiogram is ordered to evaluate current ejection fraction and volume status. We'll check BNP every 12 hours and replete potassium to higher than 4 and magnesium to higher than 2 as needed. We'll continue his GDMT as long as vitals and renal function allow. Continue oxygen with nasal cannula and will wean off as tolerated. Continue to monitor telemetry for any vital sign changes. Monitor strict intake and output with a goal of net negative 1 to 1.5 liters per day. And lastly, we'll start fluid restriction and a low sodium diet, less than 2 grams per day to support decongestion. You can go on to the next problem and plan like this. The key here is that I've already shared subjective and objective findings presentation previously, so you don't have to mention it again, but still leave them in your note under the assessment and plan part. Plus, here's a tip for diuretics conversion and frequent BMP check while on diuretics. Usually in acute decompensation of the heart failure, we double the home diuretic dose with IV form. You can easily find the equivalent between Lasix and Bumax of oral and IV forms in Google. The reason for more frequent BMP check, like every 12 hours instead of daily, is to trend electrolytes and renal function, specifically sodium, potassium, chloride, bicarb, and creatinine level, while the patient is on high dose of diuretics. It's because aggressive diuresis sometimes can cause contraction alkalosis or electrolytes imbalance. Second problem is persistent AFib without RVR. His rate is well controlled with the current home regimen, so we'll continue his home medications. But his CHEST score is 4, so we'll start anticoagulation with DOAC like Eliquis. Stay on telemetry and aim for a rate control target of heart rate less than 110. Third problem is AKI on CKD stage 3. Etiology is likely prerenal, secondary to volume overload from his decompensated heart failure. We'll continue IV diuretics as we discussed, while carefully monitoring I's and O's with electrolytes. And avoid nephrotoxic agents, and if your renal function worsens or fails to improve, we'll consider a nephrology consultation. Here's a tip. I know it sounds weird because patient's volume status is overloaded and why it's prerenal/hypoperfusion, right? So, in the setting of acute decompensated heart failure, the kidneys may sense less blood flow because most of the fluid is third spaced, meaning it's shifted out of the intravascular space and into the tissues. Next problem is chronic normocytic anemia, likely related to CKD. His hemoglobin level has been stable at 10.4, close to his baseline of 11, no signs of active bleeding, so we'll continue to monitor CBC daily. Non-insulin dependent type 2 diabetes. His diabetes is well controlled with a recent A1C level of 6.7 2 months ago, so we'll hold oral PTA anti-diabetic medications and start a low-dose sliding scale insulin regimen with hypoglycemia protocols during this admission and monitor glucose more frequently. Last problem is essential hypertension. Currently there's no active issues, so we'll continue his home antihypertensive medications and monitor vital signs and rhythm closely on telemetry. So let's see what we've been going through. Subjectively, I've described patients' symptoms and complaints from their perspective. Objectively, I've shared my physical exams, vitals, labs, and imaging. Assessment, you've listed all the problems with diagnosis and possible etiology that the patient has, including active/acute issues and then chronic stuff. For the plan, we've explained what is your strategy for further evaluation and management, including monitoring, medication adjustment, and training labs. Let me show you a few tips here. First of all, always link your plan back to the problems. That's what separates a good presentation from a checklist. And also, try to think ahead and come up with your own plans. Don't wait for your senior or attending to give you the answer. Anticipate the next move like you're already the one managing the patient. Secondly, speak clearly and with intention. Don't just read the labs, tell the story. And always check the trends. Today's creatinine doesn't mean much unless you know baseline in the past. So it's important to check the trend. And also, for some labs like NT-proBNP, be mindful to interpret the number because it can be high compared to normal reference range in the patient with a chronic kidney disease. But If it's still significantly elevated compared to a patient's high baseline, we can combine that information with clinical pictures to explain his acute decompensated heart failure. Lastly, your attending or senior will give you some feedback. If you don't receive any feedback from them, just ask them how you can improve it, asking whether it's too long or how to approach specific management in a better way, something like that. And most importantly, please don't take it personally. Please take the feedback in a constructive way so that you can improve yourself, because challenges always bring growth. So here's our last part of today's session. What are your takeaway messages? Let's practice, practice, and practice. Get comfortable with the SOAP format. The more familiar you are, the more confident and clear your presentation will become. Once you make SOAP part of your routine and become more systematic, your team members will understand you better and trust your clinical thinking. And speak up during presentations. Project your voice, be confident in what you've prepared. Support each other. Study together, practice presenting. Collaborate on better plans. That's how you grow, not just as a clinician, but as a team. And above all, enjoy the journey. Becoming a great doctor isn't just about knowledge, it's about showing up, improving every day, and never giving up. You've got this, now go crush those rounds. That's a wrap for this bedside presentation. Let me know in the comments below what part was most helpful and what topics you'd like to learn about more. Bedside presentations are where you shine as a med student or intern. This is where your attendings see your clinical thinking. As always, we care, we share, and we grow together. I'm Dr. Irene, and I'll see you in the next chapter. If you found this video helpful, don't forget to like, subscribe, and hit the notification bell so you won't miss the next video. Thanks for watching. I'm Dr. Irene, and I'll see you in the next round.